Good evening, everybody. Thank you for joining us at the Orange County Regional History Center for tonight's panel discussion. This event is in conjunction with our current exhibition called Intellite Project Florida, which helps use art to erase the stigma of substance use disorder and addiction. And we highly encourage you to check out the exhibition if you haven't had a chance to see it. It's open through April 15th. I'd like to first welcome our moderator, Dr. Thomas Hall from the Orange County Drug-Free Office. Hi, Tom. Followed by Dr. Amy Newens from the University of Central Florida. Dr. Lydia Mashisha from the University of Central Florida. And Dr. Michael Dunn from the University of Central Florida. So following the panel discussion, we'll have an opportunity for you to ask questions and provide any feedback. And this program is supported by the Florida Humanities Council. For those of you who are attending in person and online, we ask kindly that you please take a moment to fill out a survey so we can send that feedback back to our very generous sponsors. So without further ado, Tom, please take it away.
Thank you. So welcome. Looking forward to this evening, and we've got a really nice group of professionals here, lots of experience. Frank, I've known Mike Dunn for many years. He and I have been partners in crime and a number of research projects, and we've supervised a number of students together as well. Mike has a real passion for this work, as do I. Amy Newens, I've worked with her for several years, and her work around trauma is well known. She's a very accomplished researcher and works with the University of Central Florida's clinic that I just blanked on the name of.
UCF Restores.
Yes, UCF Restores. And then Lydia, I'm not going to try your last name because I'm a little nervous, and I'm certain I would.
Mashisha.
Yes, thank you. And so Lydia is another colleague of Mike and Amy's, and what I'd like to do is, Mike, we can start with you. If you just let people know kind of how you got here, and you know what your passion is around substance use treatment, and so I'll let you take that.
So I got here because I wanted to be a clinical psychologist. And at the time when I made that decision, the only thing I knew of that was the Bob Newhart show, which I don't know, people might have to be of a certain age to even remember that show, but I was a clinical psychologist with a little briefcase and went to his office and saw people, and I thought, you know, that seemed like a better deal than being a physician or better fit. But with only that in mind, and knowing I had to be a research assistant to get into graduate school to become a psychologist, I started as a research assistant and was just very lucky to fall into the lab of a very prominent scientist who, probably one of the most prominent clinical psychologists who does research in alcohol use disorder and particularly developing treatments. He was the developer of relapse prevention, which is probably the most widely used cognitive behavioral therapeutic approach to substance use disorders. And I just became fascinated with the topic and inspired by that kind of work, and have been doing that ever since.
Yeah, and Mike, so that was your undergraduate mentor, and then in your doctoral work, you studied under the former head of NIDA, is that right? Or NIAAA.
Former associate director of NIAAA.
Yeah.
Yeah.
So you've had quite the pedigree.
Well, thank you.
Yeah. Lydia.
Yeah, I am also a clinical psychologist, and I've always been interested in clinical psychology. Maybe, yeah, because I'm very interested in people and how to, the aspect of therapy has been really fascinating to me. I never considered becoming a physician, but, and so my route to where I am right now started at the Williams College, where I did my undergraduate degree, and then I was a research assistant at Boston Medical for a couple of years. And then that led me to get my doctoral degree in clinical psychology from the University of Memphis, where I studied under Dr. James Murphy. And afterwards, I went did my residency and my postdoctoral fellowship at Brown University, and then I came to UCF to join these esteemed colleagues about 1.5 years ago. So I'm the newest member of the clinical psychology faculty at UCF.
Dr. Newens?
And I am also a clinical psychologist. I went into clinical psychology because, well, I also just wanted to help people, and it seemed like a way to be able to do that. And then while I was in graduate school at Virginia Tech, I started becoming interested in how anxiety relates to substance use and how people may use substances to cope with feeling anxious. And then after completing all my coursework at Virginia Tech, I went to the VA to start doing my internship and my postdoctoral fellowship, and there I got to do some experience working with substance use disorders, and worked actually as a substance use disorder psychologist in the VA for 1 year before joining UCF.
Very nice. Well, thank you. So I want to go over my history and how I ended up in this chair. I've had a long career. That's a nuanced way of saying I'm getting old. But this morning I was adding up the years I've been in social services, and I think I was at like 35, and that seems like a long time. It's amazing how quickly time passes. I know Mike and we've worked together for about 18 years, and it doesn't seem like it's been that long. But I'm a licensed clinical social worker. I started out working with children and families. I did a lot of grief work, and I found my way into the substance abuse field kind of by accident. I had a good friend who was in recovery, and he wanted to learn about working with families and children, and so I said, well, I don't know much about substance use and treatment, and if you'll train me on what you know, I'll train you on what I know. So he was running an intensive outpatient program, and so I went to help him. And about 3 months into that, he took another job, and I became the director of an intensive outpatient program, which is frightening on one hand, that they entrusted that to me, but on the other hand, it sort of launched me in a career that I really hadn't foreseen, and I haven't looked back since. It's something that I feel very strongly about. My brother is recovering. He was addicted to methamphetamines, and he's been in recovery for about 10 years now, but it wasn't easy. I remember a Christmas that I had to change the locks on the door and on the doors at my mom's house, and get a commitment from her that she wouldn't let him in. And then when he got arrested, I had to call her every night and say, don't bail him out. And that's what it, well, I won't say unfortunately, because it was very fortunate, but that's what it took. And so, like I said, he's been in recovery now for 10 years, and he would not mind at all me sharing that story, because he embraces that. And so that's why we're here. We're here to talk about stigma and all the ways that stigma is manifest in this work. And one of the pieces that I think is important to remember is that we all have a shared experience of stigma. That may not be the same type of stigma. It may not be the same level of stigma, but stigma resonates with all of us. And so one of the pieces here I want to talk about from your experiences of stigmatized death or trauma, or just stigma in general, kind of what you found in the field of substance abuse treatment as well as research. One of the things that I learned early on and doing some of my research actually on my dissertation and academics love to talk about their dissertations. The audience may not appreciate that as much, but I looked at at how addictions treatment was first conceptualized. And it was interesting. In 1940, there was a group called the Yale Alcohol Studies, and they put together a team of preeminent physicians and psychologists, and they were going to find a cure for alcoholism. And about 10 years into it, they figured out that it wasn't as simple as curing malaria, and they found it was much more nuanced. And it just so happens at the same time, Bill W. was creating AA in Boston, I think about 1938, and so they made this sort of pivot from the medical model, or this model of we're going to create a vaccine, to really recognizing how in this case alcoholism was affected a whole family. It affected an environment. It wasn't just something that happened to someone. It influenced a lot of people. And one of the interesting pieces in the 60s, and so I'm going to kind of call out my fellow psychologists here, in the 60s, mid-50s and early 60s, both medicine, the APA and the AMA, sort of stepped away from addiction work and said, we're going to leave that to the 12-step programs. And mental health made a conscious effort to kind of create a mental health that excluded substance use disorders. And this same thing with medicine to a lesser degree. So kind of with that in mind, I know, Mike, you and I have talked a lot about you were a promising psychologist, and some people questioned why you would go into substance abuse as a substance research when you were such a promising scholar. And so,
well, I don't know that people questioned it in that sense as much as, for me there was never really anything else to study, only because with the people that I initially worked for were so inspiring, and I learned so much for them, and it was really all that I wanted to do was to better understand how people develop especially early onset alcohol use issues. And I was also, by the way, did a minor in sociology, which I'm not sure I ever told you that, Mr. Sociologist. Because Tom's PhD is in sociology. But I was always fascinated with the whole picture, not just thinking of the biological issues that might be going on with someone who has a substance use disorder, but the whole milieu, their entire upbringing, the world they live in, everyone around them, as well as what was going on in their head and how their brain was developing and how their belief systems were developing through childhood in relation particularly to alcohol use, but that kind of thing extends to other substances too. So, there's really, I never really thought of myself as somebody who was studying substance use disorders as much as really an alcohol scientist, trying to understand better how children come to start using alcohol early and in risky ways, and how we might develop better, more effective prevention programs, because the programs we had at the time, and still have today largely, are mostly ineffective, unfortunately.
So did you feel that there was so the metaphor that I know at UCF, the sociology department, the Institute for Social and Behavioral Sciences in the basement. And so we kind of have this running joke about sociology's in the basement. And so, I know in some of our conversations in the past, there's been this sense of a hierarchy of research, and that substance use hasn't always been at the top. And so,
no.
So I guess that's kind of what I was getting at. Have you experienced that?
Yeah, interestingly, there is even some stigma professionally.
Yeah.
In the sense that I had other clinical psychologists, academic researchers, make comments that made it sound like, you do substance use disorders. That's kind of, we don't know why you do that, because that's not what, we do depression, we do anxiety disorders, we do the real disorders. Whatever it is that you're doing is something else. We're not really sure why. We're going to tolerate you, but we don't really understand why you do that.
Yeah. And the reason I bring this up is I think it's relevant to our conversation in trying to understand the roots of stigma. And I think all stigma is based in fear. It's based in the fear of the unknown. And although we look at 1 in 10 people, 1 in 10 families are thought to have somebody that is either in recovery or is working towards recovery. So maybe it's not as much fear of the unknown as it's fear of the known. I'm not quite sure about that, but
I think it's people trying to distance themselves from those problems, and in a way of trying to pretend that they're not going to be susceptible themselves.
Yeah.
One of the things I teach in classes on substance use disorders is that everyone is susceptible to developing a substance use disorder. It doesn't matter who you are, it doesn't matter how much money you have or how little money or anything about your background. Everybody is potentially susceptible. Fortunately, a lot of people just don't have the right circumstances where they develop those disorders, but no one's any different from anyone else in terms of protected somehow or special in a way. Yeah. So stigmatizing people who actually struggle with these disorders is really not at all helpful for them, certainly, and it isn't going to protect you from developing a problem yourself.
So, Lydia, I saw you.
Yeah, this conversation brings up some confusion I've had for a long time in studying substance use disorders, and that is this looking at it completely separate from other mental health disorders. And there's so much overlap between substance use disorders and depression, anxiety, all of as Mike was saying earlier, in terms of how everybody, you have to think about it as the person as a whole. And the person as a whole belongs in their environment, and their environment influences how they think, how they feel, and the actions and behaviors. Everything that impacts them is kind of, I like to look at it as in a holistic perspective as to the individual that belongs within this family, it belongs within this society, and how everything impacts them. And so that's kind of my perspective in terms of understanding substance use disorders. It's part of a person as a whole, and they're just as susceptible in having a substance use disorder as having other mental health concerns. So whether that be any of the other mental health conditions that are categorized as mental health, and then there's substance use. So as you're saying, that there's that separation that happens a lot of times with substance use disorders, and I've always been confused by that.
Yes.
And it's interesting that you say that, because working so much with PTSD, something that comes up is for the patients that come see us, if they do have a problem with substance use, my thing is, if we don't treat the trauma as well, you can treat the substance use for a period of time. But if we don't treat the underlying trauma, they're likely to go back because it is part of everything else that's going on for them, and that's going to contribute to a return to substance use more than likely.
And so the reason I bring this up, erasing the stigma of addiction, that's the title of our talk tonight. I see 3 professionals, very accomplished, and yet each of you has not had to justify your work, but certainly has had to explain it to colleagues. And there's this disconnect within the field of mental health. And so can you imagine what it's like for a family that is dealing with that same kind of stigma, maybe not as blatant, not as easy to spot, because academics, one thing I've learned is they don't hold back. If they feel like they've got the leg up, they'll let you know. Yeah. Like my research is better than your research, kind of thing. But families, they often suffer in silence. and they carry the guilt and the shame, which is really heartbreaking for me. And you know, they also carry the anger as well, because it was funny as I was thinking about my brother. You know, there wasn't shame as much as anger and frustration for the pain. So luckily for me, he got into recovery, and I was able to come to terms with that anger and recognize that anger was about me and my inability to fix him. But as clinicians, I know that you've all worked with patients that are recovering, and so I'm curious what your thoughts are about that idea that, you know, here we are, accomplished professionals that have to manage the stigma. What it's like for patients and their families.
It's very difficult, and I think it starts with the fact that we've separated substance use disorder treatment from treatment of other mental health conditions, which never really made any sense to begin with, but it goes back to those days of treating it like it was something separate and different. There are more people with substance use disorders than every other mental health condition combined, and it is the most common comorbid disorder with almost every other mental health condition. So there's no really logical way to separate the two, and as Amy said, you have to treat both. You can't really hope to be successful with either. So having these standalone, you know, what we call rehab that we send people to for treatment of substance use disorders, as if that's some special separate thing, only contributes, I think, to the problem and the stigma. As if this is a thing that these people have that isn't the same as someone who's struggling with depression or anxiety, when most of those people actually have both of those things or maybe some other things. And treatment's more effective when we deal with those things at the same time, which also is a relatively recent development. Once we kind of recognized both needed to be dealt with, then we kind of started dealing with one before the other. So it was like, well, you have to go to rehab and get the substance use problem sorted out before we can do PTSD treatment or before you can get treatment for depression or anxiety. And only probably in the last 10 years or so, there's been much more broad understanding that we really need to do both together to be most effective.
Yeah, to speak to your point about how difficult it is for families. Somebody comes in for treatment and they get an assessment, and the clinician tells them, okay, we can treat your trauma or your depression, but you have to go somewhere else for the substance use disorder. Completely, we don't do that here. And so that contributes to the stigma for sure, saying, oh no, we're washing our hands clean of this, and we don't treat people with this condition. And it just adds to the shame that the person may be most likely experiencing, and that is unfortunately continued and perpetrated by mental health workers as well.
Yeah, and on one hand, I respect that notion that we don't do that here because we're not equipped to do it. Yeah. But my question is why? And so why aren't you equipped to do it? You should be equipped to do it. It's not as if this is an anomaly. And so I think our profession has a lot of growth in this area, and that we've contributed to stigma quite a bit. Amy, is there?
No, I agree with what Mike and Lydia have said, and I'm even thinking back to my time and being in a substance use disorder clinic. So patients were referred to us from other mental health clinics because they had a substance use disorder, and so now you have to come and see the person for that. And so many of them were saying, but it's really this, it's really my trauma, or it's really my anxiety, or it's really my depression that's the problem. And so, being able to, for the most part, say to them, okay, we can work on both, was a relief to them, but they still had to come to me in the substance use disorder clinic to get that.
Sure. So are there any patients that stand out to you, or any clients that stand out to you that where you've maybe worked with the client or worked with the client and a family member to help them to come to terms with the guilt and the shame, and kind of like for somebody who's listening, maybe has a loved one and they don't quite know how to address them. It's not always about the intervention where you pull people together and express my concern for you. So that's a kind of a more of a dramatic something that's done once or twice. It's not something that you do every day. And so what would you say to that family member? How do they stay motivated, and how do they deal with the stigma of a loved one having an addiction? And how would you encourage them to keep the faith, so to speak?
I think first to be upfront with people, talk about it openly with people. Don't hide it and be secretive about it. That only contributes, I think, to the stigma associated with it. So be open with people and work as a team, as a family and friends, and everyone who knows this person needs to team up to help together to help them overcome this problem, because people can overcome these problems, but it's enormously difficult, as most people are aware. So it really does take a team effort to try to help someone to overcome it. And even then they may not, but at least talking openly and enlisting the help of everyone who knows that person to help in every way they can, in a positive, accepting way, in an understanding way, instead of blaming them for developing a problem. Because it isn't their fault that they developed a substance use disorder. It's a very complex pathway towards developing an actual problem, but it's certainly nobody's fault that they ended up there. But we all have, I think, a responsibility to team up and try to help those people as much as we can. And that's the way we're most effective in treatment in general, is enlisting the family members and everyone who knows that person in a positive, accepting way.
Well,
go ahead.
And I think by being open about it, in terms of maintaining hope, I think that opens up the possibility of hearing from others things that have worked for them, things that have helped their loved ones or themselves. But sometimes it takes hearing about it and being open before others share that information with you. So I think for family members, if they can be open about it, it sometimes can help with the hope, because they can get more information that would have been hidden otherwise.
Yeah.
And what I absolutely agree with both of you. And what I'll add to that is when it takes a tremendous amount of courage to be open with that. It's important to be open and talk about it with other people, but there is definitely, we can't change society as immediately. And to anticipate that some people may have a negative reaction because of the existing stigma that exists. And so with that anticipation of not really expecting a certain response from somebody, because just in case you don't get that positive response that you're expecting, it may be really difficult to cope with that. So the only thing, reminding yourself that you can only control how you respond to how others, what others say or how others respond to you. So just having that, coming with that expectation and not necessarily depending on how other people respond to your news or what you come forth with is really important. So just tempering that expectation, but still allowing yourself to be open and communicate with others, because some people will be really warm and receptive and they'll share stories with you about their experiences, but then not everybody will. So just making sure that you have that realistic expectation and preparing yourself ahead of time before you start sharing.
I think that's the power of the 12-step programs and other programs that are self-help. You find that commonality, and those groups are very dependent on the people, because I've been to some 12-step groups that didn't feel very open, and then I've been to others where I felt like I was a family member. We could have just hung out and talked for a while, and so finding that kind of supportive environment is really important. I know that mindfulness is a really important piece, and mindfulness is becoming sort of more mainstream. in my day, if you wore a tie-dye and a headband and had long hair, you were expected to be mindful. And so that's, it's amazing to me how that has truly become mainstream. And so I'm curious, Amy, I know you do a lot of work with trauma, and I know that you do a lot of work around mindfulness. What would you say to a family member or someone who's struggling with their substance use around how not to lose hope, how to reframe and cultivate mindfulness?
So one piece of mindfulness is staying in the present moment. And so I think from the hope perspective, one thing is just focusing right now on the problem at hand or the situation at hand, and not bringing in future worries or things that have happened in the past, because that's what really gets our emotions really, really high. And so one aspect of mindfulness in terms of hope is it's a lot easier to deal just with what's going on in the present moment. So if there is a situation that is eliciting a lot of anxiety for someone, dealing with the anxiety just in that moment, not worries about that anxiety recurring in the future or all the times that it's happened in the past, but just right now, here and now, or dealing with this craving in this moment. And I think that can help with hope, because if we just have to deal with what's here right now, that's more encouraging than all the times it could happen or all the times that something hasn't worked in the past. So that would be one aspect of mindfulness that I would focus on.
Thank you. Lydia or Mike, anything you'd like to add to
that? Amy covered it pretty well.
Take a moment and be mindful about it.
Yeah.
So, and hope is a great word, and the End of Light project is about hope. And so I respect so much the families who have participated and become a family together. And I think when at the gifting ceremony, we're really going to see how this group has come together and become connected in a really special way. And so I want to give you an opportunity to ask us some questions about our experiences, both professionally. I've shared some of my personal experiences. I'm not beyond that. That's okay with me. It's interesting, professionally, there's this sort of notion that the use of self is not something that's clinically productive. Okay, some people may ascribe to that belief. I think being genuine is really important, and sometimes being genuine is being vulnerable. And so I'm willing to be as vulnerable as I can, but there are limits. So if there's any questions, either in the audience or I don't know if there's any call-in questions, I'm happy to do so.
Yeah, thank you, Tom. Do we have questions, Katie? All right, I'll come over with the mic.
While we're doing that, it's really interesting. I was working with a student who was in recovery, and he was in a master's degrees program in social work, and he shared with the class about his recovery, and the professor pulled him aside and said, you need to be careful about talking about your recovery, because other people may talk, and it could keep you from getting a job in the future. And he came to me, and he was shocked. And he said, I felt so ashamed that I wasn't able to share that experience. And I was pretty angry. I was going to march up to that faculty member and tell him in a very academic way what I thought. But I didn't. And it's just one of those things that we take for granted. There was another young man that I worked with in our recovery program. We had a students in recovery program, and he actually was recovering from pain medications. He had been in an automobile accident and had steel rods in his arms, and so he had become addicted to opioids. And so he told his doctor, "I want you to put a note that I'm recovering from an opioid addiction, so I don't prescribe me benzodiazepines, don't prescribe me opioids." And the doctor stopped him and said, you seem like a really fine young man, and I don't want to put that in your chart because people are going to think you're drug seeking. And the audience has a collective what? But it just goes to show well, for one thing, this physician thought he was doing him a favor. Like, I want to protect you from yourself. But it just shows how little understanding it is, how important it is to be able to share those needs. And so we have so much work to do around stigma. We need a really big eraser. But
so we did get a question from the web, and it's related to what you're actually talking about right now, so it's appropriate. If someone is given an opioid at the hospital for pain or prescribed one, are hospitals educating people and families and providing in-hand resources to them before they leave about the dangers or challenges they may face?
So I have some personal experience with that, but I'll hold off on that. But
unfortunately, not nearly enough. And that's why we have the opioid epidemic that we have going on in this country and globally now. Today, although the vast majority of those prescription opioid medications are being used in the U.S., much more so than any place else. But there's very little appropriate education. There's not nearly enough caution associated with handing those drugs out. And I have a little personal story directly related to that. I had a minor surgery a few years ago, and I'd been, because drug research is what I do, I had read something about how overprescribed opioids were, and particularly for minor surgeries, that many people could manage the discomfort without opioids at all. They could take Tylenol or ibuprofen and be just fine and manage it. So I was very excited. I wanted to try this. So when I went in with my wife to get the surgery, we were talking to the surgeon ahead of time before the surgery was going to happen, and said, we just want to make sure we don't need any prescriptions for pain medications. And he said, "Oh, you're going to want this hydrocodone. You're definitely." I said, "No, really. I've done my research. I was like, this is what I want to do. I don't even want it. Do not give this to us." So I had the surgery and went through recovery and everything, and woke up, and what do you think was sitting there on the table next to the bed afterwards was a bottle of hydrocodone. And it just, even when you say you don't want it, right, they insist on giving it to you. I did manage to not take any of it, actually, and it was fine. It was painful, but you can get over it. And I think we have such an aversion to pain, and if they have decided that these medications are some magic way to avoid pain, we're better at managing pain than we think we are, or can be.
Yeah, I don't think. Also, a personal story that I have. Maybe about 10 years ago, I had a wisdom tooth removed, and the dentist said, "Oh, you probably won't need it, but I'm going to give you a 30-day prescription for an opioid, and you'll have another 30-day refill." It was mind-boggling. And that was about 10 years ago. And this past year, I had another surgery, and it was a different experience. There was more limited supply, but there was no education associated with it. It would have been very important to have the doctor say, this is what you should do, and limit the use of the opioids, and just none of that, not even like a slip of paper that went home with me. And so there's still a lot of room for growth in terms of doctor prescriptions.
That said, to give some hope here, I was recently talking with some colleagues, and so this is not a personal story, but one of their stories, where they had recently gone through a surgery, and they also work in a hospital setting, and they said in their area, which this is a different part of the country, that actually you do have to, for even 2 pills of an opiate, there is education, there is paperwork that is sent home to you with educational material, and you get a naloxone kit with every single, even for 2 pills.
And this is in another state?
Yes.
Or world?
This is in another state. It is in the U.S., but a different state.
Okay.
So to offer some hope there, there are some changes happening there.
That's great. Yeah, so I have a few of the downside, but I remember in the 90s, mid-90s, I worked in an oncology unit. I was what they called a psychosocial specialist. And so I did counseling with patients and with staff, because unfortunately some of the nurses I worked with had become addicted to opioids. And so I would kind of check in with them as part of their recovery process. But I remember OxyContin was the pill of last resort in the 90s. And it was reserved for people with bone cancer. And it wasn't something that you just handed out. And I remember the first time I was at the dentist or something, and I'd moved on and was no longer in oncology, but it had been about 10 years, and they were passing it out like candy, and I stopped and said, what in the world is going on here? They're like, oh no, pain's the 5th vital sign. We don't want you to be in pain, and we want you to have a smiley face. On 1 to 10. We want you to be pain-free, and that never resonated with me. And so I had open heart surgery several years ago, and the doctor told me I was going to need this medication, and I said, no, I'm not. I'm going to make it without it. I'm good. And he berated me and said that I was getting in the way of my own healing, and if I wasn't in recovery, there was no reason for me not to take the medication. I wasn't going to become addicted, over the course of 6 weeks. And this was a very accomplished surgeon from another state. I have a friend. But it goes back to the question: is we're not educating, or we haven't educated. I know. So with the College of Medicine at UCF, they're doing a much better job with physicians in terms of educating. So I think the new workforce is much more educated than, unfortunately, Mike, guys our age. We're going to have to somehow get through that transition and see and understand, like what you said, sending Narcan home with a bottle of OxyContin or 2 pills. That's wonderful. And okay.
We do have a couple more web questions. Okay. So the first is, what do each of you feel is the most appropriate age and why to begin educating youth about substance use disorder?
Oh, I would like to take that one. My son was 8 years old, and he had surgery at a well-known children's hospital. And as he was getting his medication to go into surgery, the nurse came in and said, "Oh, I'm going to give you happy drugs." And I stopped her and said, "Excuse me? No, these are drugs. They're not happy drugs. I don't want my son to associate drugs with happiness." And she looked at me like I had 3 heads. And so I still wasn't satisfied, and I went and talked to one of the hospital administrators, who just didn't get it. They thought I was just that crazy parent who was, obviously I must have a problem with drugs. So I think it's really important, the messages we send. So when we're talking about with children, when's an appropriate time, I think it's not necessarily what's an appropriate time, it's what's the appropriate way to explain it. and so I'll defer to you all.
Age appropriate, and as soon as they begin to understand the concept of what a drug is. Alcohol is a drug, just like nicotine and opioids and all of the others. That tends to be one of the first ones that kids understand because they might see it being used in their home. They certainly see it on TV and other media. So even at the age of 3, 4 years old, kids already understand what alcohol is and understand its basic effects. And that's the time to start educating them about the fact that this is a drug and it has certain effects, and these are exactly what the effects are. And it's not a happy drug, and it's not something to just go and enjoy all the time. It's something that's potentially dangerous.
Can you talk about some of the research you did with like younger children around brand loyalty and alcohol? Is that?
So it was actually was part of that was asking young kids, and when I did this work probably in the mid-1990s was when I was still in graduate school, and my faculty advisors at the time on my thesis and dissertation committee thought it was nuts that we were asking third graders and second graders about alcohol. They thought they don't even know what alcohol is, much less what the effects are. It turns out they absolutely do. Virtually all of them knew what alcohol was and actually knew a lot about the effects of alcohol already at that age. And it's something that we found that developed as kids get older. The way they understand the effects of alcohol goes kind of hand in hand with early and risky drinking among some kids. And we found some ways to kind of reverse that process in those higher risk kids to reduce that risk and to hopefully overall lower their risk for developing an alcohol use disorder eventually.
I don't have much to add to that. My research is with adults, and I haven't raised children. My son is only 1, so I'm learning right now.
Well, you should go home tonight and talk to him.
But it makes sense to me that this whole, once they are understanding what it is, and there's a lot of information coming at them, and they need help from the parents or the adults around them to help them make sense of it.
We have some data that show that those ideas and beliefs about the effects, particularly of alcohol, have an effect 5 years later. That is, you can measure a kid in about 5th or 6th grade and find some things about them, about what they think about the effects of alcohol, that predict the ones who are going to be problem drinkers even 5 years down the road. So these belief systems are tremendously powerful, and that's why we need to be talking to kids early and frequently about, and this isn't just alcohol. I mean, we did this research with alcohol, but we found that it applies to all other drugs, too, that we've looked at.
All right, and our final web question actually comes from Teresa Clower, who is the founder of the Into Light Project. And so she asks, there's been a common belief that we are predisposed genetically to alcohol and drug addiction. Is this not the current belief?
Ooh. that is a big.
Well, that's a loaded question. Yes.
Yeah, and it's one we talk about a lot.
Yeah.
So there certainly are certain biological predispositions that some people have that make them more susceptible to developing a substance use disorder. It's very complicated. We've spent literally billions of dollars trying to sort this out, most on alcohol, but with other substances too. We've found that there are numerous genes that seem to interact in complicated ways that will predispose some people to be more likely to develop an alcohol use problem. But when you look at the whole population of people who develop alcohol use problems, half or so who have that predisposition don't develop a problem. And the majority of people who have an alcohol use disorder don't seem to have an identifiable biological predisposition. So there definitely is a biological factor or factors that work in complicated ways for some people, but that certainly doesn't explain the whole problem. And I go back to what I said earlier, which is that everybody is susceptible to developing a substance use disorder. Even if you don't have a biological predisposition, you can still develop a problem. It'll be a long time, I think, before we fully understand those biological factors. One of the leading genetic researchers on alcohol use disorder made a statement at a conference a few years ago saying that it'll be at least a century before we really understand the genetics of alcohol use disorder and are able to actually do something about it. That's a whole nother and separate, more difficult problem.
Well, and I'm glad that for many, they haven't had to wait a century. But from a sociological standpoint, I'll speak as a sociologist. I think we have to look at the nurture part of this as well, and so that nature-nurture dichotomy, nature being the heredity, but the nurture has a whole lot to do. So your environment, for some people, substance use is a way of escape. It's it's a rational choice. I know that sounds kind of crazy, and I may get hate mail over that. But if you're a sex worker and you've got no family support, and and this is the only place you find relief from pain, I would say that's rational use. Now, obviously, that's not a state that we would want people to move out of that state. But I think it's really important to recognize that humans, by nature, we tend to do things because they work, or we have a belief they work. To my knowledge, I don't know that I've ever woke up in the morning and said, I want to see if I could make this the most miserable day possible, and I'm going to take every possible risk. I think what's more likely is that people find themselves in situations and they cope in ways that they feel like are beneficial, and often that coping lands them and sometimes tragedy, sometimes not as much. But I know that trauma plays a big role in that, and so I'm guessing from somebody who does trauma research, you've probably seen a strong correlation between people who are managing post-traumatic stress disorder and substance use at the same time, and which came first?
Absolutely, and that's a complicated question because we know that using substances can put people in situations that can put them at risk for traumatic events.
Right.
And then we also know that experiencing a traumatic event and then experiencing anxiety and depression and other symptoms after that traumatic event can lead people to use substances to cope with that. So more than likely, it's a bidirectional relationship for a lot of people that can perpetuate over time sometimes.
Yeah. Well, when I have looked at data from Orange County around some of our data on overdoses and overdose deaths, we do find that there's a sort of a random distribution throughout the county in terms of socioeconomics. But we also found that there were some concentrations in areas that were high poverty and high crime, and so I think that it's a complicated picture, and that's why I think one of the best ways to manage that is to figure out how to be nice to each other. I can always tell the kind of day I'm having when I'm driving home. If I'm blessing people who are driving crazy, or if I'm blessing them in a less blissful way. It's trite as it may sound, there's something about the positive energy that of forgiveness. There's a great quote, grace is the face love wears when it meets imperfection. And I try to remember that. Some days I remember it more than others. Some of my staff are here, and I can see them going, "Okay, yeah, you didn't. That wasn't yesterday." But it's aspirational, and I do think that is protective. And so cultivating that sense of just being nice. I guess I want to leave it with that, and so is there anything that you want to add to that? I don't know what we're at on time. I'm guessing we're about up.
We're doing pretty well on time. I I wanted to see if there were any of our
Okay.
in-person audience members who had questions. We've got some great questions still pouring in from our online
wow.
viewers. But is there anyone here in the room that would like to ask a question of this wonderful panel? Be right there.
Feel free to comment as well, but you have to be on the mic. There's rules.
It just really hit home earlier when you were talking about the stigma, and I did lose a son to substance use disorder, and I try to talk about him as much as I can, and you can tell people are uncomfortable, and it's like, I don't want you to be uncomfortable.
Right.
I want you to embrace what I have to say about him.
Yeah. Yes.
That's, you know,
Right.
I want people to talk about my son
Yes.
and anybody else who lost a child or a loved one to substance use disorder.
Mm-hmm.
That's, and you know, I couldn't agree more. You know, we need to talk more openly about it and not hide these things. My best friend from graduate school died of an overdose on heroin. He was a clinical psychologist, a faculty member at a major university, a specialist in addiction and substance use disorders. And knowing all of that didn't help him and didn't save him. So, you know, as I said earlier, it cuts across all kinds of people at all levels of education and expertise and professionals. So in my private practice, I see a lot of people who you wouldn't necessarily associate with having problems with pain medications, opioids, or even alcohol use problems. But it affects everyone, from the CEOs who seem the most polished and professional that you could imagine have these problems too, as well as everyone else. So we need to talk openly about it, and I think that's the best way to start removing the stigma.
But I think that we're uncomfortable with death in general, and you know, one of the pieces I think about Kubler-Ross and the stages of grief. And when I worked oncology, I had a family member, a patient whose family member said to me, I don't want to get to that final stage of grief. I want to remember my wife forever. And you know, it was one of those moments where I thought, wow, I have so much to learn. You know, I thought I knew something, and this notion of, you know, stages of grief, like these static things you go through. I'm going to bargain, and then I'm going to come to some resolution, and as if in some way it just erases a whole life and memory. And I understand, you know, it was a metaphor, and I'm certainly not. I'm not calling into question Kubler-Ross. She was much brighter than I ever was or will be. But I do think we have to be careful about seeing grief as a line and not a circle. You know, it's I like to think of it this way. You know, when somebody close to me dies, I want to feel when I have that recollection, I want to feel it 100%, because that means they're still alive in me. I don't want it. You know, I don't want my grief to be at 30%. You know, my goal isn't 15 years out. You know, I'm gonna have 10% of that feeling. No, I want it to be 100%, because that means, you know, that shows how important that person is to me. And so I think that that's a message we need to try to get out more as a professional. You know, when we talk about grief and loss, that we're careful to not make it too easy to compartmentalize that loss, and in some ways undo the life by the way we cope with the loss.
Yeah, just a statement about the stigma. My wife and I lost our daughter a little over 7 years ago. to a drug overdose. And we'd been going to a personal psychologist for probably 6 months, and then someone had mentioned to Diane about a group that was meeting. And we thought, well, why not? Let's go try it. We went in, we sat down, and first time there, they kind of isolated us for about half the meeting. And then the next time we were there, we had the chance to introduce yourself, tell us why you're here, and if there's anything you'd like to share with us, which I did. And I said, you know, our daughter died of a drug overdose, and that's why we're here, and we're trying to get through this. And so finally, I think it was the next week or the next month that we had a meeting. Everybody had something happen to their child or relative that had nothing to do with drugs. Within 6 months, there was at least, maybe out of 15 couples, there was at least 8 or 9 couples that were sharing their story that their child had died of a drug overdose. Within another 6 months, half of the people that we were going with the first time that we were ever there, all of a sudden they had a remembrance of how their child died. They were able to come out and say it and talk about it, and but it's a stigma. It's the worst in the world, and you know, Diane here is going to tell you a little.
Well, the only thing I wanted to add was, you know, you talk about erasing the stigma, reversing the stigma. It's so hard because, you know, it's not only just your friends or neighbors or whoever that you don't want to talk to about it, but it's also the medical profession. It's law enforcement. It's even the movies, you know, how a person with substance use disorder is portrayed. So it seems like it's just such a force that we have to go after to do this. But, I mean, we've got to start somewhere, right? So I'm just so thankful, you know, that, you know, the community's coming together. You know, our daughter Tyler Ann's on the wall downstairs. And, you know, very happy to be a part of this. So, but yeah, it's going to be a huge undertaking. Yes. But I'm thankful we're going to be a part of it.
Thank you for sharing that.
Yes.
It sounds like you gave those people permission and a space to be able to talk about that, which is hugely helpful for people.
It takes some longer than others.
I'm sure. Yeah.
Big barrier to overcome.
After you lose a child, though, it's almost like you don't care anymore what you think, right? So it's almost like you feel freer to just go out and say, what's going to happen? You've already had the worst thing happen to you in your life, so who cares if somebody looks at you, you know, disdain or raised somebody if something happened.
Thank you for sharing your stories with us. It really does mean a lot, and you've also shared your stories in the exhibition, and the oral histories we collected through the Intellite Project exhibition are going to be a part of the History Center's permanent collection, so it's going to continue to allow us to tell that story about addiction. We have some really great questions that have come through the chat, so while I pass the mic along, I wanted to ask a question as we make that transition. We've talked a lot about stigma, and I think you know, there's a particular vocabulary that we're trying to use, and we're trying to help others understand. Could you just share a little bit more about how vocabulary is an important part of erasing and removing stigma when we are talking about substance use disorder and addiction?
Well, fortunately, there have been some much more attention focused on the kind of language we use professionally to describe substance use problems. So previously, up until just a few years ago, the official diagnostic terms were either substance dependence or substance abuse disorder, and that's changed in the most recent Diagnostic and Statistical Manual of Mental Disorders, which is a giant book about this thick that lists depression, anxiety, and a few hundred other things. And so now they're listed specifically as substance use disorders by substance, so alcohol use disorder, opioid use disorder, and whatnot. which I think is, moving in the right direction towards destigmatizing the issues people have with them. Some of the major academic journals are changing their names to get away from that stigmatizing language as well. Some of the National Institutes of Health, National Institute on Drug Abuse and National Institute on Alcohol Abuse and Alcoholism are both considering name changes to try to destigmatize these issues somewhat. There's some other things in that direction.
Yeah, the AP in 2017 came out with a style guide for writing about substance use disorders, which spoke to the power of language, and it's still we're working, or journalists are working to try to break some of those old ideas of how to talk about substance use disorders. But the style guide I find very helpful, and it's respectful. You wouldn't call somebody a cancer, it's somebody who has cancer, but not a cancer. And in the same way, we don't refer to people as as a disease. We refer to people as people, and so that's part of how language matters.
It's more, just to add to that, the idea is to use person-centered language. So the person with a substance use disorder, somebody with an addiction rather than an addict, or just referring to them by their disease, exactly as you said. So I think that's overall in mental health world, that's a language that needs to be changed. It's because the stigma really is not only specific to substance use, it's all of mental health. And so I think that language, it's starting to change, and it's really important that that work is happening.
I know when we talked about how way back in the day, people that were mentally retarded, right? And so we nowadays, you say that to somebody, it's pretty offensive. We just hope that one day the term addict is thought in that same term. And so I think that's
Well, it goes back to, as far as Florida goes, it goes back to legislation. So I also have a daughter that's developmentally disabled. Well, all the language that referred to people with mental disabilities was retarded. And when she was a baby, I was told she was retarded. Well, the state of Florida went through a process years ago to remove the word retard and retarded from all government documents, and now it's developmentally disabled. And we are part of a group called Project Addiction, Reversing the Stigma. And that's kind of one of the things we want to do here in the state. We want to see some legislative changes as far as this subject goes. So.
It's amazing how much your voice can change things. And so it's a beautiful thing to see how much power people have when they can unite.
So we do have some more questions from the web that we'll get to. This question, I think, speaks a little bit to what our audience was speaking to. What's the best way to support family members who have lost a loved one to an overdose?
I think exactly what you guys were describing, having a supportive network of people that you can feel like you can relate to, and being able to go into those groups and other people to have this conversation, because as you're describing exactly, you want to talk about your children, you want to share your experiences of what was going on with you and with your family, and so having that outlet where you have a supportive group can be really helpful to start with, until you're feeling more comfortable to step outside of that network and start exploring other environments and other social networks.
And I think in terms of being supportive to the family, it's important to keep in mind that, as Tom was talking about, it's not a linear process that they're going to go through. And so how they were yesterday may not be how they are today. And what they needed yesterday may not be what they needed today. What they wanted to talk about yesterday may not be the same. And so I think being open to asking people where they're at or what they need. One thing in working with interpersonal things is learning ways to ask people, how can I support you? There's a common thing of going into problem solving when people just want validation, or vice versa. And so learning to ask people, and that by asking them, you can actually then do what they truly need, and not making assumptions even based on where they were the day before.
Yeah, I worked with a parent who had lost a child, and she had a child who died. So even that language, lost, no, he died, but she said to me, I can't take hearing from a family member or friend to ask me if I'm okay. Like, what do you think? So she said, if I could tell people civilly, don't ask me if I'm okay. I'm not okay, and I'm not going to be okay for a long time. The idea that you think I could be okay tells me that you have either no heart, or you totally are misreading the situation. And I know I've done that before. Somebody who's experienced a loss, and my thought was, I'm trying to be comforting by saying, "Are you okay?" But logically and rationally, it's kind of not a bright thing to say. And so, and that's part of the complicating piece, because those people who are wanting to help, they don't want to say the wrong thing, and when they do, then that creates a cycle of guilt. So then they're going to withdraw, and now you're going to feel even less supported. And so that's why I think it's just really important to be able to talk openly and bluntly about what's happening, how you're feeling, and not use these pretty phrases to try to cover up the loss.
So our last couple of questions are somewhat related, so I'm going to compound them. They're both related to information and resources available. So the first part of the question is if someone has a concern about a loved one, what are the resources in our community that you would recommend? And then the other is, as time has gone on, there are different things that are sort of in the public consciousness of like, these are things we need to be concerned with. Is there anything coming onto the scene or on the scene right now that people should be looking out for and staying away from?
That's a broad question.
Well, but that's something you and I have talked a lot about recently.
Right.
With the opioid
Yeah, we're
crisis.
limiting this to drugs, right?
Right. Fentanyl and carfentanil, and that's not going away anytime soon. If anything, it's actually going to get worse over the next probably 5 years or so. I think you were saying the DEA is saying.
Yeah, to put this in perspective, if we take a 10-year period of time from 1987 to 1997, 303 people died of AIDS, and the highest year was 1995, 42,000 people died. If we look from 2010 to 2020, 628,000 people have died of a drug overdose. And last year was the highest year ever. It was almost 92,000. And so fentanyl is driving that. And if you've never heard of fentanyl, look it up. Fentanyl is the biggest threat to our nation's health right now that I know of. And so that's the short answer, is we need to be sounding the alarm about fentanyl. But I also think we need to be sounding the alarm of what can we learn from how the AIDS epidemic was managed, and how we saw in year 8 a decrease from 41,000 to 30,000 in year 9 and 16,000 in year 10. How do we see those same kind of changes with the overdose deaths? And so that's something we need to ask our politicians, we need to ask our policy members. And so this is, that's the other takeaway from that.
Yeah, and it's not a war on drugs that solves the problem. We've been fighting a war on drugs for over 50 years now. It's harm reduction. Harm reduction is what works. We have mountains of data now that support that approach. There are many things you can do to reduce the death and destruction associated with alcohol and substance use problems. And harm reduction is far and away the best, most effective way to do that. It's not something that, people struggle with it in some ways when we're talking about things like needle exchange programs, things like making Narcan widely available.
Right.
You and I have struggled to make Narcan more available on campus at UCF. And it's, there's some pushback at times, like, why do we need that? We don't think we have a problem here. Well, the problem is everywhere, and you need to have that Narcan on hand at the place, at the moment that problem happens, or you can't save that life. If you do have it there, you do save a life, and we've seen that happen already on campus at UCF, as well as lots of many places, as you know, around Orange County. Obviously, that's what you do.
Well, and the stigma around medication-assisted treatment. It hasn't been that long ago when in residential treatment programs, you couldn't be treated if you were on an antidepressant, much less Suboxone or buprenorphine or methadone. I mean, I knew a woman who was on methadone, and she gave birth, and the nurses found out she was on methadone, and every time her baby would cry, they would come rushing in because they attributed it to neonatal abstinence syndrome, when in fact her baby was just crying like all the other babies. But she told me, I felt like less of a mother, and this is what I need to do to stay sober. And so yeah, there's so many levels of stigma, and it takes an educated public. And so again, thank you all for standing up and making your voices heard.
Resources. Question about resources.
Well, I'm going to let you.
I was going to let you.
Because the mic is coming in. The hook is on the way. So there's lots of resources in the community. 211, you can call 211 and they will connect you with community resources. Our website, drugfreecoalition.org, we have a whole page of resources. My phone number is 407-836-7335. You can call me for resources. And I think that, is there anything you all want to add about resources? I know there's a clinic at the college that you see private patients.
Yes, so UCF Restores, we are located on UCF's campus. Right now, we're fortunate to be able to provide services to adults who have experienced traumatic events free of charge. And so if that applies to anyone, we are a resource to and would be happy to see people. Our website is ucfrestores.com, and so you can look that up.
All right.
All right. Thank you, everybody, for joining us this evening. Thank you to our panelists and for Dr. Hall. I also want to thank the Orange County Drug Free Office. They were our partner in the Into Light Project Florida exhibition and a huge supporter of ensuring that we are erasing the stigma of substance use disorder. I also want to give a big thank you to Orange County TV, who's here tonight. Not only are they recording this program, but they're also broadcasting it around the world. So I'm so glad you gave out your phone number, Tom, because anyone can give you a call.
That's awesome.
So thank you all so much for attending. If you'd like to come and see the Intellite Project Florida exhibition, as I said, it's on display through April 15th at the Orange County Regional History Center here in Orlando, Florida. Thank you.